There's some interesting points about not creating dependency related to that, which was an issue that we came up to a lot. This background picture, by the way, I chose it is because this was from a tuberculosis vaccination campaign that Mary helped carry out in Bolivia, but it wasn't for people, it was for cattle. But people apparently can be infected by eating the cattle and stuff. So it is the same disease, as I appreciate it. They had a number of TB vaccination campaigns. And what was interesting about this one was the idea was to set up a number of local groups, in this case rural healthcare workers, who could be trained to carry out the campaign. So one of the things that we wanted to avoid is you could just throw a lot of money at an issue and parachute in a lot of specialists from Europe or the US and a lot of their money, and they just do all this vaccinating and then they leave. And in the process, first of all, there might not be local buy-in to begin with. So was always the starting point for any intervention that we had at IADB or World Concern, was to make sure there was local government, host country buy-in, that this is something that the local country was really supportive and perhaps even willing. So you really need both. And in World Concern, we were always making sure that at the federal level, they were happy with that we were there and understood in general what we were trying to do. And then it became very important at the local level, whether that's a mayor or a tribal chief or whomever it would be, really wants this. And if all possible, if they can somehow share in the cost, if it might just be the smallest a little bit of cost sharing, it is really useful. I mean, that little concept of ownership is always important. So not only should they have buy-in, but they should have some ownership. And so here we certainly had that in these rural areas of Bolivia. And what was really neat is that most of the vaccination work was carried out by locals. And here's a young woman, her name was Natividad, and she's being trained how to give a vaccination for TB. And so
was she someone who had a medical background, or just a villager who was interested?
Well, what they did is they went around and planned it. They talked to the leaders and said, we want to do this. If you want to do it, if you'll supply workers and resources, we'll provide all the medicines and all the training. And so they kind of came up with an agreement of how it was going to be carried out between the locals and the international aid organization. And everybody had their role. And then they, at each village, they recommended one person who would become trained to do this. And so this is actually a team of about 12 people from 12 different villages who were all chosen. And it was kind of a regional program. I'd say maybe like a county. And these are villages within that county. And they all were selected and agreed to do it in their own time. And our agreement was, we'll train you. And so they had about half a dozen training seminars so they could learn how to do it. And then we supplied a lot of the medicines. This is one of those training sessions. And you can see the woman in the background, she's got her notebook because she's going to be doing it next. And she's taking notes, which is really awesome. So the idea is you want to have local buy-in to begin with, local participation, local cost sharing, and then you want to leave with local capacity building. So when you're gone, they're able to carry out this or other similar campaigns themselves. So a lot of aid principles that I've seen occur, it happens with food aid a lot. The U.S. is terrible about it in the past, is that we might notice that in Kenya, for example, when we lived in Kenya, there was a food shortage for a time period. And then the U.S. sent in all this enormous amount of food aid, but it flooded the market, and it flooded the market so much that all the prices dropped for corn. The local farmers were not able to sell their crops because the price had dropped so much. And so after this food aid program was over with, all the poor farmers had basically gone bankrupt and weren't able to produce crops the next year. And so we created a permanent damage to the system. So do no harm is always, of course, that's a medical principle, but it's also a foreign aid principle. So certainly it's a double principle for foreign assistance in healthcare, is do no harm to the system. I know in this program here, one of the things that they tried to do was to set up local veterinarian offices. They were really basically pharmacies more than anything. They tried to have a broader campaigns to convince all the farmers, look, you need these dewormer medicines and these other kind of medicines. They're worth the expense. And so then they would try to stock these local pharmacies so that they could be sustainable on an ongoing basis, and so that the local people would buy these products from the local supplier. And of course, you could only promote medicines that made sense in that local context. So if you identify certain medicines that are very efficacious for that area and have a good cost benefit even for these very poor people, and you can convince them to start buying these products through the local pharmacy, then you're creating a pharmacy that's sustainable, and you're expanding the supply of all these products that are necessary. With SAMs, I know whenever we have a local partner, one of the questions that people ask is, is there a local partner with the capacity to absorb this aid? There's a kind of a technical term called absorptive capacity, which is, is the local community have enough people who are willing and able, or their local institutions like churches or civic organizations or private sector organizations that can help us implement this so that it can be, absorbed. So, what's interesting in Compassion International, what they do there is, one is, this is at the real micro level. So they come up with the compassion. One has to only operates in countries that want them to be there. It's interesting too, they also, when they look at an area, like when we started working in Gulu, Uganda, they didn't have any projects there because they said, we've been in Uganda for a decade or so, but we've never operated in Gulu because we considered it kind of a conflict zone. We just don't think it's prudent to be operating in an area that's a conflict zone because the risk of the project failing is so great because of crime or lack of civil society operating and functioning. We can't really carry out our program without some degree of political stability. So you do a risk assessment. You think about in Congo where they're trying to do these Ebola vaccination campaigns, and they're just constantly literally dealing with guerrilla warfare. It's so impossible to carry out their work. But in northern Uganda, it just wasn't safe, and they just didn't think they could carry out their program. So by the time Mary and I started working there, it had settled down, and they said, we probably could operate in Gulu now. So our project with the Anglican Church was the very first compassion project in Gulu, which was very exciting because it had the political situation had settled down. So they did a risk assessment and said, okay, it's a super poor area. It's where we ought to operate. It's now more stable, so we're going to go there. And then the church would get set up and they'd start a compassion program. And then donors would give money to the compassion project. And their criteria would be, they go to the local church and say, you find the people who are the poorest in your community and they get into the program first. And in Gulu, the way they defined the poorest was, okay, we're going to go to all the what they call orphan-led households, which was a really strange label. Like, well, what is that? And they said, well, we've had all this warfare and Civil War and stuff. There's so many orphans. There are many households that are led by the teenage kids, the oldest child in the family, and they have several siblings, and so there might be 3 or 4 siblings that have no parents, and the 15-year-old was in charge of the family, which is just so tragic. And I thought, well, okay, that certainly qualifies. So they went to the orphan-led households first, and then got all those kids in the program. And then they began to look at other difficult but less terrible situations to determine who participates. So the way they work is that, so the sponsors give $38 a month into the program. No cash ever goes directly to the children or to their parents. They use about 2/3 of the money to pay for school fees. They'll tell the school, okay, this child, we're paying their school fee. And then the child goes to school and they have a roster and they know that their fees have been paid for them and they can go to school. They give them vouchers so they can take those to the store to buy the uniforms. And once a month, they also get vouchers for, occasionally to buy some clothes or books or things like that. So here you are giving money to the families or giving goods to them. And the question is that sustainable? And the issue here is, well, what we're doing is we're educating a young person. We're basically getting them educated and some healthcare checkups and things like that. That's right. They do have an annual checkup. So The degree of healthcare services depends on the nature of the compassion project and how little or how much healthcare is available in general to the public, and so whether the project tries to take that on or not. But they typically do have at least annual regular checkups that they cover, so a physician will come to the project. So the projects meet every Saturday for like 3 hours, and they teach the kids, Bible topics, healthcare issues, all kinds of subjects, and help them with their homework and stuff. And so that's the context under which they could, get all various types of assistance. And on some of those Saturdays, a physician will come in and check the kids. And that's sustainable in the sense that hopefully by the time that child is 18 years old, they've been educated and they're an adult, has a good moral system of training and is healthy and becomes part of the fabric of Ugandan society. But I think their technique for never giving cash to anybody is very important. And I think you could apply that to bigger operations. Well, it's interesting in the places that I've worked. So the Inter-American Development Bank, so that money comes from a multilateral institution, meaning an international organization owned by basically most of the countries in the world. I mean, the projects I worked on with infrastructure were actually loans, but they could be grants. So you have international organizations, of course, that would include the UN, the World Health Organization, World Bank, or the official aid agencies like USAID provide funding. But again, the idea is they get matched somehow by local government support, and then even the local participants somehow share in at least some minimal cost sharing, so they value the product that they're getting. And with World Concern, it was a philanthropy. So these were donations from private individuals. I also worked for the U.S. government's foreign aid program for a while. In that case, it was U.S. government money. The Inter-American Development Bank was international organization money, and World Concern were private individuals donating. And even in the microfinance programs that we did in Bolivia, so we provided the initial capital to fund these village banks. The participants also always had to put in funds as well. So it was always kind of a matched funding. So we felt like they had skin in the game, as they say. Probably applies to some degree to healthcare interventions as well. So I can describe the process the Inter-American Development Bank goes through in allocating funds for infrastructure, and I have to guess it's the same for healthcare. So the first is they'd say, okay, is this proposed intervention consistent with the host government's development plan? So we always had to know that there was a country strategy. Every other year, the bank and the countries where it operated would develop a host country strategy. Basically, the host government saying, hey, we and Ethiopia, here are the 5 major things we're trying to accomplish. We want to reduce malaria. We want to, reduce birth defects or whatever it might be. And they come up with their major criteria. And so if you're presenting this proposal to the board of directors to approve use of these funds, it had to be shown that it was consistent with the country strategy. So that was a way to ensure that we had host country support. And also, if that countries always had to be a member of the bank, their board member always had to vote in favor of what we were doing to make sure that we weren't doing something that the host country didn't want. And then we'd say, well, okay, great, but we'll do this in Ethiopia, but Ethiopia is a big country and their country strategy involves a lot of stuff. Why are we picking this particular project? So we always had a list of development indicators to sort of demonstrate this country had high development impact. I've never done it in healthcare, but we always had to do something. We had to do something called a financial rate of return, which is to show how we got our loan repaid. But there's also something called the economic rate of return. The economists sort of say, look, cost of this intervention, in this case, say a vaccination, is going to be X, Y, Z. This cost savings from, productivity and lack of illness would be X, Y, Z. So they do a lot of, it's inexact science, but basically what they call economic rates of return to demonstrate that the project has economic value. And of course, you have to put dollars on human suffering and health and things like that, which is not easy to do. But there was always a screening process of saying, how developmental is it? And then you'd say, the other thing that's kind of interesting at these development banks, they'd also say, look, okay, so it's consistent with the government strategy. You can see how it has economic and health benefits, and so it's highly developmental. There's local capacity to help implement it. There's a plan to build local capacity through the project. But can this project be evaluated? And so it was an interesting requirement that said, we want to know that this project has what we call, smart indicators, specific, measurable, achievable, relevant, and time-bound associated with it. So that going in, we can say, hey, is there a way that we can tell if this project is successful or not? Because if they're not, we don't want to do it. We want to know that there's a way to measure the success. And so the people that kind of designed the program had to come up with these development indicators. One, that help demonstrate why you should do it. But secondly, if they were things that could be measured well, it would be a way to evaluate the project going forward to kind of keep it accountable.